succeed. A chance to make friendships that could last forever. And tuition that will leave you debt-free, so you can save money for other things. Nights, online, and weekend classes. Recognized as an Aspen Top 10 community college, discover yourself at EPCC, the best place to start.
Welcome to the Amanpour on PBS. I'm Christiane Amanpour in London, giving you the global view. I've covered the world for nearly 3 decades, and I'm dedicated to bringing you all the facts. Please join me for conversations with newsmakers, world leaders.
Good to be with you, Christiane.
Artists and writers, the people who define, change, and challenge our world. That's Amanpour on PBS.
Weekdays at 10 p.m. on KCOS.
Strokes don't just happen to old people, and what is considered old these days anyway? Tonight's show talks about all kinds of strokes in all kinds of people, not just those who we believe are at high risk for stroke. We're going to talk about symptoms, intervention, and rehabilitation, and during this hour we have experts answering your questions about strokes and some of the strategies that can help save lives. As you know, this is a live show, so stay with us and think of some questions of your own that you'd like to call us with this evening, 881-0013. This evening's program is underwritten by the Hospitals of Providence, and we also want to thank the Texas Tech Paulo Foster School of Medicine for providing the medical students to man our phones, and also, as always, the El Paso County Medical Society for bringing the show to you. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us this evening. We are going to be talking about strokes this evening, prevention, treatment, and rehabilitation. And we have 2 great doctors with us this evening. We have someone who's new, and it's always nice to have somebody that's new. I'm going to spell her name first so you know where I'm going when I try to pronounce it. Dr. Chigolum, so Chigolum, and her last name is Eze, and it's Eze. So thank you so much for joining us. Dr. Eze is a neurologist that's joining us with this evening. And then we have Dr. Brian August, who's the veteran of the show this evening. So thanks for having an easy name. And you are a rehabilitation physician. And again, we were talking about when I came to see you 10 years ago, and you were beautiful and fixing some of my pain. So thank you so much for that. On this program this evening, we have 2 medical students who are going to be answering the phones to you, and that is going to be Roxanne Lerma. You've seen her around before. And we also have Mikey Jimena, and you've seen her around before too. So thank you very much. Did you guys get cards, by the way? If not, we're going to get really big pieces of paper with the questions. Okay, gotcha. So I would like to start off with talking about, this is nice to have a neurologist and a rehabilitation physician here this evening, because neurology and strokes, there's a lot to be said about that, but we don't always talk about the neurologist component to it. So in your role all day, every day, as a neurologist, I know you talked a little bit about specializing in epilepsy too, but as a neurologist, what does that specialty pertain to when it comes to your world and working with strokes?
Thanks for having me. So we first of all would want to know what strokes are. Strokes occur when you have an abrupt disruption of blood supply to part of the brain. Now, what does a neurologist do? Most times in most big hospitals, when people have a stroke and present to the emergency room, neurologists are called. The neurologist either appears in person, or you have a teleneurologist set up where the neurologist interviews the patient, family members over the big screen TV. And what does a neurologist do? The neurologist, in a very fast manner, tries to determine if what the patient presents with is consistent with a stroke, or if it's a stroke mimicker, because there are other things that could look like strokes that are not strokes. So the neurologist assesses the patient right on the spot, gives the patient, yes, there's a stroke, no, there's not a stroke, orders the initial test. Sometimes the emergency room docs do the initial battery of tests that help the neurologist to decide what to do. If the patient presents to the ER within 4.5 hours of onset of symptoms, the neurologist is able to give an okay to give clot busters, assuming it's a type of stroke that would respond to clot busters. And we're going to talk later about the different types of strokes.
Excellent. Yes, I've got that down too. And that's interesting too, because people just hear, oh, he had a stroke. Well, what exactly does that mean? Dr. August, let's talk about, we're not going to talk about this part yet, but later on during the show, I would love for you to give a case study and follow a patient through high risk, stroke happens, where do we go from there? Is there another high risk later? But in general, for you, how do you explain to the audience what you do all day, every day in the area of, I don't want to call them stroke victims, but stroke patients, I should say?
For the stroke patients, and usually they're initially worked up at the acute hospital. Then what they do is come to the acute rehab if they're appropriate. Appropriate patients, it's going to depend. Somebody can be too bad and they may need to go to a skilled nursing facility or some sort of institution like that first, or they may be too good and just able to walk home and you really have no sequelae as a result of what had happened with the stroke. The people in between, then, I mean, it depends upon what type of stroke. There's left-sided strokes, right-sided strokes. Generally people that have left side of the brain strokes that affects the right side. A lot of times they'll look worse, but cognitively they're more intact. People that have right-sided strokes, right side of the brain, that affects the left side of the body, a lot of times they look good, but they're actually worse cognitively because they're unaware of their left side. So first we assess, see what they have. It's called a neglect if they have the right-sided stroke and they don't pay attention to the left side of the body. Assess where they're at. Do they have speech impairments? Do they have swallowing impairments? Swallowing is very important because they can aspirate, and if they're at risk for aspiration, you want to modify the diet or even have them at NPO where they're not eating anything, and you have something through the IV or parental feeding. Then it comes down to sometimes they have more problems, and usually they're going to have more problems with the upper or lower extremities. Usually when the stroke, as it starts to heal a little bit and you start to get some recovery, usually either the arm or the leg will be worse.
And that's a great question too, especially in the world of neurology, how people not necessarily recover physically from a stroke, but what is happening then with the nerves and how the nerves are building upon themselves and healing and trying to fix what's happening. We're going to talk about that in a little bit, but what I'd like to do first is talk about the different kinds of strokes that are most common, and then how and what risk factors affect each one of them. So what are the most common types of strokes?
The most common types of strokes are the ischemic strokes. The ischemic strokes account for about 85% of the stroke type. Now, what is an ischemic stroke? An ischemic stroke occurs when you have a blood clot blocking a blood vessel that supplies some part of the brain. That is an ischemic stroke. So within a few minutes, a few seconds actually, brain cells start to die. The patient has symptoms, and that's an ischemic stroke. Now, there are subtypes of ischemic strokes, like embolic stroke. That means that a blood clot formed elsewhere in the body, most often the heart, and traveled up to blood vessels supplying the brain. Then we have the thrombotic strokes, where the blood clot forms at or around the vessel that supplies the portion of the brain. Now, 85% of strokes are ischemic strokes.
Okay.
What are the risk factors for ischemic strokes? You have broadly three broad categories of risk factors. Let's talk about the medical risk factors that we can do something about. You have hypertension, commonest risk factor. People who have hypertension have 1.5 times more likely to have a stroke than people who do not have hypertension or high blood pressure. You have diabetes mellitus. You have high cholesterol. Those are medical risk factors. You also have heart conditions like atrial fibrillation, which is where the heart has an abnormal rhythm and it stores blood or pools blood, and the blood easily forms clots.
And that's part of it, the ischemic stroke as well?
That's the ischemic stroke risk factors.
Okay.
Then you have the risk factors that you cannot modify. You have age. So the older you are, the easier it is for you to get stroke. An older person has strokes more likely than younger person. You have
That's not like that with any other disease or condition, is it? No, we just need to stop aging.
unfortunately, we can't. And then you have ethnicity. African Americans, people of Hispanic origin, probably because they have more of the medical risk factors that predispose to these strokes, are more likely to have ischemic strokes. Now, the second category of stroke or second type of stroke would be the hemorrhagic stroke. This is also called the bleed stroke. So instead of something blocking a blood vessel, you have a blood vessel bursting and leaking blood. So with the leakage of blood, you don't have as much blood supply to the more distal or further parts of the brain that blood vessel supplies. And you also have blood, which is an irritant, touching the blood cells. Now, the hemorrhagic strokes only account for 15% of strokes, but unfortunately, they are the more dangerous type of strokes because most of the mortality from stroke would be when you hear that, oh, he had a stroke and didn't make it and died. Right. Likely it's a hemorrhagic stroke. The main and most common risk factor for hemorrhagic stroke is poorly controlled high blood pressure.
Okay. And that's a category in both. But and you had an excellent point, because often you hear that people have had a stroke and now they're going to go visit Dr. August, and Dr. August is going to help them get back to their new normal, so to speak. And so that's always the question. And it's the heart attacks, like, well, he had a heart attack, but he was at work the next day. How does that happen? It's just one of those things. It's a theoretical question. But the idea is, Dr. August, if I can take it to you, so people who have had, and let's go with ischemic strokes, and there's different types, of course, but let's go with a pretty severe case. And once the stroke has happened, let's say they were able to get to the hospital within that 4-hour magic window, so to speak. 4.5. 4.5. Got to count those extra 30 seconds. So when is it that rehab starts? Does it start almost immediately? Does it start, especially when you're talking about something like swallowing or breathing, if that's an issue? And maybe you can talk a little bit more from there.
Well, what's going to happen, initially they're going to be sort of worked up to find out what type of stroke one, that they did have a stroke, two, what type of stroke it is, which, helps a lot. By the time they come to me, though, after the initial workup, it's not going to matter whether it was hemorrhagic or non-hemorrhagic. What's going to matter is what their deficits are. The only way it's going to matter in terms of hemorrhagic versus non-hemorrhagic, in a hemorrhagic stroke, you're not going to want to do anticoagulation for a period of time because you'll be at more risk for bleeding. And you don't want the stroke to extend by more blood going into the brain, causing more damage. The non-hemorrhagic ones are going to be almost universally on blood thinners. And the reason that they need to be on the blood thinners, one, usually they have some sort of weakness, and one or both limbs are not moving the same way they are. That way the circulation doesn't flow the same way. It's going to be more prone to having blood clots, which can flip up to the lungs and cause pulmonary embolus. So most of the people who are on rehab, unless there's some definite reason that they shouldn't be on blood thinners, they put them on blood thinners because they're in rehab, because most of them have decreased mobility.
Okay. On that note, I'd like to, and I should have asked this first, my apologies for that, but when we're looking at the diagnosis of what type of stroke it is, and I'm throwing this out to both of you right now, because I should have asked this before, because if you're looking at, okay, my mother's not acting right, my husband's not acting, they're slurring their speech, there seems to be those warning signs. So first I'm going to ask you to give the warning signs. And then I'm going to ask you how, once you get to the hospital, what are you looking for to figure out what type of stroke it was? And I should have asked that first. I've jumped the gun a little bit. But what are the warning signs if you see someone? Because a lot of times you don't notice it yourself, I understand. Somebody else usually notices it in you. Is that correct?
Yes.
Okay.
Sometimes you do too. It depends on the symptom. So you would have facial droop. Okay. So if you think a patient has a facial droop, or your family member, you'd ask them to smile, and you'd notice that one side of the face doesn't move as much as the other side. You would notice they could complain of arm weakness, leg weakness. They could complain of or you could notice that their speech is slurred. You could notice that they're not speaking. They're not able to name things. You could notice also sudden onset dizziness, especially in the elderly. The patient is imbalanced, dizzy. Those are typical signs of stroke. Even sudden onset confusion is something that makes you think, what's going on with mom? What's going on with dad? I need to call 911 and I need to get them to the hospital.
And if you are feeling it yourself, the symptoms, I mean, there's no pain, I understand.
Most times.
Most of the times, no. And if there is, that's probably a hemorrhagic stroke? I don't know.
Not really.
Okay.
Sometimes some thalamic strokes could cause pain, but that's so rare.
But it's really just all of a sudden you're off.
Numbness, weakness, facial droop, dizziness, difficulty speaking, looking for words, even confusion.
Nice. I say nice, but this is what, it's nice to be able to explain all of that. And here's my point, and I hope that you agree, but don't try to drive to the hospital. Maybe don't get mom or dad or husband or wife to drive you. Call 911. And the reason we say that often on this program is that the ambulance can call ahead for you. Once you're in the ambulance, they can take at least a small assessment of what's happening, sometimes a bigger assessment, and be able to call the hospital and say, oh, we need to get you there, and we need to get you there, whoever needs to be there. So call 911. It's just worth it. Now, once they get to the hospital, and I know that you kind of come in later in the game, but how does one diagnose? They've come in from the ambulance, they're there, now do I have to figure out what's happening to you? You're having a stroke, okay, is there an MRI? Is there a CAT scan? Is there...
So typically we do a brief assessment, and there is a way we do it, a very, very fast orientation. We check their arms, check their legs, check their sensation, give them a score. There is a score that is called the NIH stroke scale that tells us how big or how small the stroke would be. We immediately wheel them in for a very urgent emergent CT of the head.
Okay.
The CT of the head actually helps us differentiate if it's an ischemic stroke versus a hemorrhagic stroke, because the CT of the head would most likely show us blood if there is bleeding into the brain, and then tells us this patient is not a candidate for clot busters. Now, if the CT of the head looks okay, which it often does within a few hours of a stroke, then the patient, if he doesn't have any contraindications, would now be a candidate for IV-TPA, which is what we call the clot busters. We can talk to them and their family, get consent, and get that going within as fast as we can, because time is brain.
Yes, exactly. I like that. Time is very important. In that situation, too, are you able to see on the CAT scan, and next time I'm going to ask you guys to bring images, because that's always so nice to be able to see that on screen. Are you able to see the clot? Are you able to see that all of a sudden the blood stopped flowing? Or
so on a CT scan, most times you're not able to see the clot unless it's a very big clot in a very proximal vessel. And if you see that clot, you know it's going to be bad. So you're arranging for IV-TPA. You're also calling a subspecialist we call a neurointerventionalist, and we have a couple in the community that's good. So they can come in and see if they can try to retrieve the clot. So there are also other things we can do, not just give IV-TPA, but there are mechanisms for getting that clot out if possible.
So that makes me curious. So where do they enter? Do they enter in through the neck, or how do they enter to go in and get the clot out?
So they enter in through the femoral artery.
That's crazy. That's cool.
How?
It's just cool because you're thinking that's really far away from the head. So I would love for you to explain that to the audience, because I find it fascinating. I just think it's absolutely fascinating. So they go in through the artery.
They go in through the artery, through the leg, go right up to where they visualize the clot and try. They have different retrievers. They try a couple of retrievers to see if they can pull the clot out. Sometimes they inject the type of thing we do for the IV-TPA. They can inject intraarterial TPA to try to dissolve that clot. A lot of times you have good success and you have blood flow back to the area that would have been dead without their expertise.
Okay. Nicely explained. And Dr. August, let's now, and I actually want to stay on this topic just a little bit, but I'm going to ask you, because I want you to have a turn. When is there ever any chance of the clot breaking up, or is it always in one solid point, or could it break up into several different pieces and go to other parts of the body? Is that ever a thing? Or is it, because I know you're trying to dissolve it at the same time when you're going up there.
So theoretically, it could break off, but a lot of these devices that retrieve the clot also have baskets that go to the distal portions and try to catch any distal fragments that move out.
Okay. Okay.
From what I remember, unless they've changed, one of the, the biggest risk of when you do the clot breaking type therapy is if you, sometimes it can cause bleeding in and of itself, even if it's not a hemorrhagic stroke, and that's one of the dangers. And that's part of the reason why you only want to do it within the first 4.5 hours, because usually after that there's too much damage done to make the risk versus benefit in a good balance to be able to do that.
These days they're pushing the boundary. They're doing it up to 8 hours in select patients. There are new papers that are saying you can do it up to 24 hours in even more select patients. But we typically would do it because if it's a big stroke, it's going to be a devastating stroke, and oftentimes that's the only chance the patient has of having any semblance of not so disabled life outside of the acute period.
And how often is it, Dr. August, that you would, I don't know if it's something I'm asking if it's a percentage of patients, but what percentage of patients actually do kind of make it within that 4.5 hour window? And then maybe let's take it to the 8 hour window, because I'm thinking too that if you happen to not be with someone at the time and you're not sure, you're feeling weird, but you don't really know why. So I'm like, you know what, I'm going to lay down for a while. So now 4 hours pass, maybe you fall asleep, maybe you don't. So maybe take us through after the 4.5 hour period and what starts happening, because you're the guy that has to rehab someone, hopefully if it's in the 4.5 hour window, but then sometimes
usually
not
the
as
ones
well.
that are before the 4.5 hour window that they're going to actually be able to do that on, I'm not going to see.
Oh, beautiful.
So
okay.
Most of the, unless there was some complication, and the complications are much lower now than they used to be because they're much more select in terms of who they're going to do it. A lot of times technology will come out and they'll try and generalize it to everybody. And when they generalize it to everybody, it doesn't work. So, nowadays, especially with something like a stroke, strokes can be devastating. So they're very select in who they pick in order to do the clot busting type therapy. So there's not as many complications, and the people that I usually see at the rehab unit are the ones that wasn't available to them because they've waited too long.
Okay. And the percent, and that's where it gets kind of hard to ask the questions. And so the people that you're seeing now, when you were talking about if there is the problem happens on the right side of the brain, then usually the left part of the body is affected. Is that right? Did I hear that right earlier? Yeah. So actually, the left side of the brain, it affects the physical function of the right side more. But if it happens on the right side, the cognitive and other issues, the neurological issues are affected a little bit more. Did I hear that right?
On the right side, that's correct.
Okay.
Usually people look better. If you see somebody and you're talking to them, they look like a lot of times they look like there's nothing wrong, but cognitively there is, because they completely ignore and don't pay attention. In fact, in severe cases, you could hold somebody's left arm up, put it in front of them, and say whose hand this is, and they're not going to know.
Goodness. Okay. And of the right or left brain, is there one that happens more than the other, or is that a random thing?
That, as far as I know, is random.
It's a pretty random thing? Yeah. Okay. And so the chances of rehabilitation, working with both the cognitive issues and then the physical issues, what is there cognitively that you can do? And I guess that works with the world of neurology quite a bit too. If the cognitive portion of a person, is that something that is more difficult, obviously, to rehabilitate?
It's more difficult in all aspects, whether it's stroke rehab or rehab after orthopedic surgery. What happens is a lot of times people have baseline dementia. When they have a stroke, it usually gets worse. Even if they don't have a stroke, they've had an orthopedic procedure, they've had anesthesia, which sometimes will back them up a little bit and they'll look worse. And the fact that they're not in their home environment where they're used to, they're going into a completely new environment where there's so many new things coming at them, it basically overloads them and they look much worse than they would be when they're at home. So, if somebody is elderly and they have some cognitive changes already going on, which a lot of times the family doesn't recognize because they're used to it, they'll look much worse when they get into the hospital, and then you have to explain to the family, and some of them aren't willing to accept that their loved one is actually starting to get some dementia.
And And there's not that there's a coming back from that, right? It's just something that you just
usually when they
learn
get
to-
home, once things stabilize and they get home, they will actually look better. And once they're in their home environment, if it's just straight changes that are new from the stroke, then sometimes you have to just wait and hope that things heal up. What you do is you present stimulus to them. Usually the speech therapy speech therapist is going to be the one that's going to work with that aspect of the stroke, and they'll try and present them with things to stimulate their mind, colors, pictures, and try and retrain somebody to be able to communicate. Sometimes they can't communicate at all. It's called a aphasia, where they sometimes it's a global aphasia where they can't say words and they can't understand what's going on, or sometimes it's an expressive aphasia. They understand more what's going on, but they can't express themselves or voice words, and there's combinations of those that occur. But the speech therapist is usually the one that works with that, also with the swallowing problems.
And it's a matter of just retraining the patient, correct?
Well, you have to go over and over. And the people that have baseline dementia, too, a lot of times it's much more difficult.
Yeah.
Because they already had that to start with, and then you add something that's compounding on top of that. So basically you go over and over it again. It's repetitive stuff, like if you're learning to play the guitar.
Right.
You play the same note over and over again, and hopefully it sticks.
Yeah, nicely said. So let's talk about, if we could, let's talk a little bit about prevention before we go further, because there are hemorrhagic strokes. I don't know if there is a preventative, you were talking about high blood pressure, hypertension. So just in general, the good fit, but if we're talking about specific stroke prevention, maybe take it from there, and maybe you can talk about both types of strokes as well.
So specific stroke prevention is managing risk factors. The greatest risk factor, medical risk factor for stroke, is high blood pressure. A lot of people walk around with high blood pressure not knowing they have high blood pressure or hypertension because it doesn't give you any warning symptom. And a lot of people who have high blood pressure don't take their medication prescribed by their primary care physicians because they don't have symptoms and they don't know why they should be taking this medication. Unfortunately, that puts you at risk for a stroke. Okay? And if it's a bad stroke, that's a life of disability.
Okay.
Management of your diabetes mellitus is very important. Management of your cholesterol is very important. Now, for the blood pressure, we ask patients to aim for a systolic blood pressure. That's the top number on the blood pressure measurement of 120 or less, and the diastolic blood pressure, that is the bottom number of 90 or less. Okay. For diabetes, you want to make sure that your hemoglobin A1C is within that's the check for the blood sugar, is within known parameters, which is less than 5.9. For the cholesterol, you want to make sure that your cholesterol, the total cholesterol, is less than 200, and the bad cholesterol, which is the LDL cholesterol, is less than 100 or less than 70. What are the other things you can do? You could lose weight, okay, exercise. We advocate for people to exercise, moderate exercise, 5 days a week, 30 minutes. Something like walking around your neighborhood, taking a lap in the pool, stuff like that. The big one, again, for lifestyle changes would be stopping to smoke. Cigarette smoking puts you twice at risk for having either the ischemic stroke or the hemorrhagic stroke. Those are the things people would work on, and they would hopefully lower their risk for having either ischemic or hemorrhagic strokes.
And go along with diet too, because that always helps. Yeah, let's talk about It's like I
helps.
almost want to talk about diet, but we talk about it on every show.
Diet really helps.
Yeah.
It's difficult to wave aside diet. Diet helps you with your weight. Diet helps you with your cholesterol. A good healthy diet helps you with your diabetes. And a good healthy diet with low salt also helps you with your high blood pressure. So diet is kind of intertwined in all the risk factors we had described so far.
Yeah. So pretty much any show that you watch, just try, if you can, stay healthy. I know it's so easy for us to say that and have it come out of our mouths, but it helps with everything. It helps with any kind of surgery. We've been talking about orthopedic. How does that help? Well, if you happen to have an operation to recover, it would be good to be somewhat healthy too. Question here from the audience: if there is a stroke, if somebody already had a stroke, what is the probability? And let's say it's a stroke and maybe it was a 4.5 hour window. They didn't have to go see you, which is wonderful. What are the chances, however, of a same individual having a stroke again? Is that something that then becomes high risk?
The patient is, so having a history of a previous stroke puts you at risk of having strokes later. So we talk about secondary prevention in these patients. So outside the 4.5 hour time, so say a patient comes in at 3 hours after the stroke and gets the clot buster, and we get the patient into the hospital, we try to figure out why they had the stroke. We do an MRI of the brain to clearly tell us where the stroke is. We do a CT angiogram checking the blood vessels of the neck to see if any of them is narrowed. Are there plaques there that could have predisposed the patient to having a stroke? We check the heart. We do what we call an echocardiogram. What does that tell us? It tells us if the heart is pulling blood, there's the heart pumping out blood effectively, because if you pull blood, you're putting yourself at risk for having blood clots that could travel out to the brain. We do telemetry, which is where you run cardiac strips for 24 hours, 48 hours to make sure that the patient doesn't have atrial fibrillation. Now, atrial fibrillation is another big risk factor for stroke. That is where the heart beats irregularly, okay, and because it beats irregularly, you now have the increased chance of having clots, and the clots can break off and travel to the brain. And if we find this in this patient, we would anticoagulate them after the initial 48 hours to prevent them from having further strokes. So one of the things we do in the acute setting, which is the first 48 to 72 hours, is to find out why the patient had the stroke and to try to guide them towards preventing further strokes.
Okay, so this is I'd like to ask you for me. I have a heart valve that does all kinds of crazy things, and I have AFib, and so my big thing is stroke, 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 stroke. So someone who, luckily I don't have high blood pressure, luckily my cholesterol is very low, but for someone who does have AFib, has a valve issue, in general, are there any preventative factors there? Say if they are in good shape, this and that and the other. I'm totally being selfish by asking this question. Dr. August, he was like, hey, I know.
I got a question for you. Are you in constant AFib, or do you go in and out?
No, I go in and out. And thank you for asking that. I did wear a heart monitor once for an entire month, just to kind of see where I am. And it's the doctor said, well, that's normal for you. But there will be times that I just feel like my heart's going to run out of my chest. It lasts for a couple of minutes, and it doesn't come back for days, if not weeks sometimes.
The problem is when you're going in and out of AFib. If you're in constant AFib, you're not really at an increased risk for developing the clots. Maybe a little bit, but not significantly, and you don't actually have to be on blood thinners. If you go in and out of AFib where the rhythm is changing, what that does is promotes clotting within the heart chambers, and that's when you have the risk of throwing up embolic clots. So if you're going in and out of AFib, you should be on, unless there's a significant contraindication, you should be on blood thinners. If you're constantly in AFib and it stays that way, you don't need to be on the blood thinners.
Okay, so I probably should talk to my doctor about some.
Are you on blood thinners?
I am not, but I do take the baby aspirin. Talk to me about that, because you know what? It does.
Aspirin is not considered. That's good to prevent heart attacks.
Right.
From vessels clotting. You know, you're getting clots there. You have basically atherosclerotic plaques.
Right.
And preventing platelets from closing off those little narrowings. The aspirin helps with that, but in terms of for throwing emboli from what goes up to the brain, those little blood clots, the aspirin is not considered to be sufficient.
Dang it. All right. We've talked a little bit, my doctor and I have talked a little bit about blood thinners, but it just didn't seem that I'm thankfully, knock on wood, not at the point yet that the cardiologist feels, or
if you are actually going in and out of AFib,
yeah,
then you from as far as I know, do you have any?
Yeah, and this is what I do before we start the questions. This is all the information we have. This is like my 3 minute of information. So feel free to give advice, because there's a disclaimer before and after the show that just says this is all the information that we have, and it's just the best that we can do at this point.
I'll refer to my neurology colleague.
So we do look at a lot of other factors. When a patient is in AFib, you're like, okay, should I have this patient on anticoagulation or not? We look to see if the patient has congestive heart failure. Is the patient older? Older patients are at more risk than younger patients. Does the patient have other vascular risk factors? Like, are you seeing atherosclerosis when you do the CT? Is the patient diabetic? All those are the things that we're going to consider and then give a patient a point. So somewhere on the point system, you would now evaluate is the patient, because with being on anticoagulants or blood thinners, you also run risk of hemorrhage. So being on blood thinners is one of the risk factors for hemorrhagic stroke. So you and your doctor would decide the benefits versus the risk, and depending on which outweighs the other, the physician decides, and you, again, empowering you to decide this is what the best way to go at this time. So there are a little bit other things that we put into play when we decide if a patient will benefit from anticoagulation.
And I love how you said how you can advocate for yourself. You know, that matters a lot, because I think a lot of patients don't do that. And that's one of the reasons that we ask you all not to wear the white coats on the show, because you're people, and we want people to realize that people can speak to people and advocate. So no, I love the way that was said. This is a great question from the audience that we haven't touched base on yet. We were talking about strokes and the clot strokes, and then aneurysms is the question here from the audience. So they'd like to know what the difference is, if you can explain. So an ischemic stroke versus an aneurysm.
So an aneurysm is when you have an abnormal dilatation of the blood vessel, okay? If an aneurysm ruptures, you could have a hemorrhagic stroke. Now, hemorrhagic strokes are of two types. You have bleeding into the brain, which is what you see in a lot of conventional strokes, or bleeding outside the brain, so between the brain and the covering of the brain, which is a space we call the subarachnoid space. When you have a ruptured aneurysm, you would have a hemorrhagic stroke, but it will be the subtype that is called a subarachnoid hemorrhage, which is a different ballgame altogether.
Goodness. Okay, so if you are bleeding, so if the bleeding is happening into the brain, that's where because you were talking earlier that the blood is an irritant. I've never heard that before, but absolutely makes sense to me. So I wrote it down. But with blood being an irritant going into the brain, that's where some damage happens. But if the aneurysm bursts and it's on the outside of the brain now, between the brain, I guess, and then and that's where a lot of times people have to get a hole in their head, get the pressure taken off.
So with that, with the subarachnoid, with a ruptured aneurysm, again, we have to call. We do a CAT scan and we see the blood, where the blood is tracking, and we know it's a subarachnoid hemorrhage. One of the first things to do is to clip that blood vessel that is bleeding. So the patient is stabilized, a neurosurgeon or a neurointerventionalist is called, and luckily in this community we have a lot of them who are experts in doing this. They go in and clip that blood vessel. And then we have the patient most times in the intensive care unit, most times intubated, because a lot of times, not all the time, a lot of times when you have the subarachnoid hemorrhage, the patient complains of a headache and oftentimes becomes unconscious, so they would need to be, you would need to support them, support their breathing, support their circulation till you get them back to where they can be able to do that themselves.
So just recently, I've had two people in my life that have had exactly what you're talking about. Something all of a sudden happened and they had a headache like no pain they've ever felt before in their life. And one was a 22-year-old Olympian, literally my nephew. And it was, I forgot what they call it. It's like a raspberry in the brain. I wish I had brought the wording with me. And another person just had bleeding. They call it a brain bleed. And again, it was outside, but neither one of them were strokes. So immediately you would think, oh, that's a stroke, or they thought they were having a stroke, but there was that immense pain first. And I would love for you to talk, I know this is a stroke program, but because that is so similar and so interrelated in how people describe what's happening, going to the hospital and then diagnosing that. You were saying that with the MRI, I guess you would do an MRI with a CAT scan first. And when does the MRI come in? So the CAT scan, they have to see or not see certain things before the MRI comes in?
Sometimes we do a CAT scan to screen out and put the patients in categories. So patient comes into the ER, the story is the worst headache of my life. Sometimes with weakness, sometimes with other neurologic symptoms. You get them in, they do a CAT scan and you see the blood tracking. Again, the first thing to do is to stabilize them and get someone to stop
that
the brain bleed.
Okay.
The dilated blood vessels, some people are born with that, okay? Of course, high blood pressure makes it worse. Sometimes you would do a scan for some other reason and you see that aneurysm. And depending on the size, you might decide to clip it or might decide to follow it with time.
Okay. And that's always the interesting part of what's going to happen. Everybody's so different. Dr. August, with everybody being so different, question here is, how long does it take usually to start seeing results from therapy? And that is such a broad question. I completely understand it. So you can take that any way, in any case study way that you would like. So how long in general until some things start coming back?
Probably within about 3 to 7 days you're going to see some return. But a lot of that, I mean, some of it is going to be related to the therapy by starting to get people moving and exercising, and a lot of it too is also going to be due to some healing and recovery of the brain tissue.
Okay.
So you're going to have two things that are ongoing that can actually help somebody to look better. One is some recovery within the brain itself, and the other is actual exercise and movement and starting to work on things like transferring.
Like transferring.
You can see improvement within 3 to 7 days. Sometimes
That's actually quicker than I expected, or than I expected to hear.
Well, I'm talking about after they come to rehab. So there's already been usually maybe 5 days to a week before they come over to the rehab unit.
Okay.
Is that about right? 5 to 7 days, unless there's complications.
Unless there's complications.
Yeah. And then on that note too, is there, because I always think of when I was young, oh, my grandmother had a stroke and one side of her body doesn't work, and it seemed like that never fixed. And so I'm 51, so let's say that was 30 some odd years ago. I am still young, thanks for saying that. But let's say that was 30 some odd years ago, and so now, today and now with medications and rehabilitation, I feel like that's not the case anymore. Where grandma had a stroke, yeah, she had a real difficult time moving one side of her body for a while, but now she's doing pretty good. If you can kind of talk about what the rehab situations have been over the last couple of decades.
They're pretty much similar, except they have more knowledge. There's a lot of stuff done on the front end when somebody is treated with the basically clot busters. They're better at determining what type of stroke. There's more medications available. But a lot of it, you'll still have somebody that ends up with an arm or a leg that is what's called their spasticity, and you get increased tone after, as time goes on, if it doesn't heal correctly. You'll still have somebody that'll have an arm that's, usually it's twisted in like this and contracted. I mean, you still get that.
Yeah.
And that's, when I had alluded to earlier in terms of the arm or the legs more affected, a lot of times what will happen is if somebody has a pretty dense stroke where it affects heavily on one side of the body, you'll end up with an arm or a leg that will come back and the other won't.
Gotcha.
Usually you don't stay completely like that, although in some severe cases you'll have somebody that basically has spasticity and increased tone, and basically you have to work with that.
Question here from the audience, and I know we talked a little bit about before the show that you specialize in epilepsy. Question here from the audience is seizures and strokes. Are they related? And I guess that's a good question too. Number one, how we differentiate between the two, but I think we've kind of explained what a stroke looks like. But maybe talk a little bit about seizures and strokes.
Sometimes, on rare occasions, seizures could be the presenting symptom of a stroke. So you have a patient, you know, checking their arm, and you're like, what's going on? What's going on with that? Come to the ER, CT is done, and you see the patient has had a bleed. But oftentimes, in cases of stroke, we see seizures later on. Stroke causes damaged brain. And when you have damaged brain, you have aberrant discharges, aberrant communication. And when you have abnormal communication and abnormal discharges between the brain cells, it results in seizures. So 10% of patients who have strokes often end up having seizures, and as an additional diagnosis that we need to manage.
Okay, so that's usually an after the fact, not a risk factor, so to speak.
No, it's not a risk factor. It's after the fact is one of the complications of a stroke that could happen.
Okay. I'm not going to go to the questions there for a couple of minutes because we're about 13 minutes out before the end of the show. It goes fast. On that note, what I'd like to do is stop the questions and ask you all if there's something that we have not covered yet that you would make sure we'd like, let's get this covered before the end of the show, or if there's something that we have talked about that you'd like to expand on. So feel free to, or Dr. August, might you have some things? I know I saw you do that thing. It's like, let me look. So Dr. August, I feel like we haven't spoken as much to you. Is there anything that you'd really like to get across to the audience this evening?
You had mentioned, and actually both of you were talking about, for example, anticoagulation with AFib. There's lots of things you can do, and there's lots of medications you can take. What you want to do in terms of making a decision on what you're going to do for your body is, first of all, to get informed on what's going on, whether you read yourself, a combination of reading yourself, get some information from your doctor, then you go over the possible treatments that are available. What it comes down to, though, is you really, if you're informed and cognitively able to, make a decision in terms of what you want to do in terms of medications to take or not take. As long as you're informed and your doctor presents all the statistics and gives you all the information, it comes down to being honest with yourself in terms of whether you want to take a medication or not.
So here's another question. I'm just going to throw this out really quickly. I feel like on the market there are so many blood thinners. There's so many different types of blood thinners. Are there different categories in when people take certain types, or am I thinking?
Well, there's different levels in which you take. I mean, there's Coumadin type medications, which Xarelto, or there's several new ones that are similar to. Xarelto is one of them. Eliquis, and I mean, there's a slew of those now. But
and are they all in the same family? I mean, do they physiologically have the same effect in the body system?
There's a few differences in terms of what their bodies to be, allow them to be used for. And I mean, what it comes down to is studies. Some of them will show, well, this one really isn't approved yet, the FDA for this for AFib, or this one's not approved for this type. They're very similar. Sometimes the statistics are very close in terms of whether they approve one or not, but those are similar. Those are the heavier hitters in terms of blood thinners, the Coumadin type medications. The next step down, you have stuff like the platelet inhibition medications like clopidogrel, which is, they have Plavix, Effexor, Effient, not Effexor. Effexor is an antidepressant, but that's the next step. You also have aspirin, which is a very good, especially if you haven't had any severe disease. It prevents platelet aggregation, which prevents, basically having heart attacks, strokes, and then you weigh your risks. Any of them, you start off with aspirin. The next step up is sometimes you combine that with like Plavix or clopidogrel, which is the generic. Then you go up to the Coumadins.
And I know this is not a show on hearts or cardiology, but I know in the old days, or even in movies, it's like, oh my gosh, he's having a heart attack, pump some aspirin into him.
But the thing is, when you say it's not on that, they're all related. In the way, I mean, they used to say that the eye is the window to the health of the body. The reason being is all these diseases, heart attacks, strokes, a lot of problems with the eyes, the kidneys, peripheral vascular disease. It all comes down to blood vessel disease. So that if you have disease in one area, there is an extremely high risk to have disease processes going on in other areas.
And that makes perfect sense, too. Anything that we haven't discussed that you'd like to get across?
We've discussed this, but I want us to emphasize it. The best thing to do when you have a change in your neurologic status is to get 911 and get to the emergency room. It might end up not being that you've had a stroke, but the idea of, and I see this every day when I round, oh, I had the weakness and I thought it was going to go away and I went to bed. And I woke up and I was more weak than I was when I went to bed. Now you're outside the window and we can't do anything for you. We're just going to look to see why you had the stroke and send you over to Dr. August to take care of you. So what I want our audience to know is there is no harm getting 911 and getting to the emergency room and finding out, oh, it wasn't a stroke. Or, yes, it was a stroke, but I'm in time to get life-saving disability preventing therapy from. I'm in time to get life-saving and disability preventing therapy.
Right. And this is something, too, so I know that often and it's terrible, because wouldn't it be nice if everything in the world of medicine was free, you know, but often it's like, oh, you know, then there comes the bill later, or the costs. But it's worth it, you know. I say that because I'm running the medical show and I get it. But there's a question of there's no way I can afford that. But no one is going to turn you away, and that's something that's very important. An ambulance will get you. They will get you to the hospital. They will treat you regardless of the ability to pay. So definitely do that, and I echo you 100%.
The other reason to call 911, even if you feel okay, if you are having a stroke, sometimes it progresses. So you can start off okay, you could get in your car and start to drive. And as you have progressive weakness that gets worse and worse from changes going on within the brain, you might not be able to make it there safely.
Yeah.
And if you have a car accident while you're having a stroke, I mean, you're in a lot of trouble.
That's bad news. I'm getting some questions here. Boom, 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 slowly, quick. So here is a question from the audience. Is an impaired sense of time an early sign or indication of a stroke? And maybe you can talk again about just being generally confused. It's like it's 6 in the morning, it's 6 at night, what's happening? Maybe we can talk about that as a symptom.
So sudden onset confusion is a sign of a stroke. So you talk to mom, you come out to the living room and like, Mom, what's happening? She's not able to respond, or she responds and is like, what am I doing here? What's going on? She's a little bit confused. She asks you the same question over and over again. Get her to the emergency room.
Okay, yeah, it's another question here from the audience, and I'm just kind of going through these as fast as I can, and I don't know if this is, so a caller said that they had a stroke, not sure how it was diagnosed, affected one side of the body, and then the following day, it transferred or moved to the other side of the body. I don't know if it was in place of or now that both sides are affected. Again, this is all the information we have, so it's not something that we can answer. That may not be something that we can, because I have never heard of that either. Okay. I am going to butcher the word of this, but the caller read in one of the national newspapers about a procedure called testrectomy that benefits patients of stroke.
Then is she saying thrombectomy? Then that's
let's say it is. Maybe it's just misspelled here.
Thrombectomy is that procedure we talked about where the neurointerventionalists go up and retrieve the clot.
Thrombectomy. That's right. I do remember that. Another question from the audience. I'm trying to respect all these and get them out there. Normal blood pressure, cholesterol, and sugar, active lifestyle. Had a heart attack recently, 2 weeks ago. And you're calling, and good job. So you're doing okay. But they want to know. Dr. August, I'm going to throw this at you, but they want to know, is heart attack and stroke related? What are my odds of getting a stroke now that I've had a heart attack? And maybe you can talk a little bit about the relations of different issues that are going on within your system.
Well, I mean, and they had a heart attack is what
they had a heart attack 2 weeks ago, yes.
There's different things that can cause a heart attack. Somebody could have been severely dehydrated and basically lost perfusion to part of the heart and caused a heart attack. If that's the case, I mean, it was, basically from dehydration, they have no underlying blood vessel disease. If they found that they had underlying blood vessel disease in the coronary arteries, one of the coronary arteries or several, then there's an increased risk for problems in the brain, the kidneys, peripheral vascular disease. So it depends upon what the workup showed when they initially went in for the heart attack. The other thing is, too, probably what trumps everything is genetics. You can't beat genetics. You can work with genetics and try and minimize genetic problems that you may have inherited, but you can't beat genetics. So if somebody in your family, that's why they always ask family history. Does anybody in your family have a heart attack, stroke, diabetes? If somebody has any of those entities that are positive in your family history and they're blood relatives, then your chance of having something like that increased significantly.
Yeah, pretty high. And always kind of look around when you're looking at risk factors on that. Question here from the audience. I survived a stroke in 2003 and had the symptoms that we're all talking about. Their symptoms were bad balance, numbing on the left side, numbing of the left face. They said, now, however, I am maxed out on GABA penitence. I don't know what the... Okay, so what, and the question is, what should I do? So I don't know who to throw this to. You're looking at me like, oh. So 2003 was the stroke, the original stroke. So we're looking 15 years later.
So there are other medications that could be added to it. So she's probably still has some numbness, maybe neuropathic pain. And there are other medications that could be added to gabapentin. She should either see her rehabilitation specialist, her primary care doctor, to see what other medications she will benefit from.
Okay, so there are definitely other options, bottom line.
Well, I mean, specifics. I mean, you could change it to something like pregabalin. Sometimes that it's similar to the gabapentin, but it's a little newer. Sometimes works a little better with less side effects. Duloxetine is another one. I mean, there's several other things like that that you can use. But the other question is, it sounds like she's getting worse. So, I mean, you'd want to see at least her primary care doctor to get worked up in terms of why she's feeling worse. Because you shouldn't feel worse that far out from a stroke. I mean, from 2003, you're talking about 15 years.
Yeah,
I mean,
and we don't have an age or anything on here, unfortunately.
But you still shouldn't feel worse. There might be something else going on that needs to be looked at.
Yeah, agreed. Question here from the audience, and I'm going to make this the last one because we're really kind of running out of time, but thrombectomy, the question is in reference to what we were talking about, who in El Paso can do that? Is that something that most hospitals are equipped with, or?
There are two main hospitals, I think three. You have a group at the Texas Tech, Dr. Mawood, Dr. Catherine, and Dr. Rodriguez.
Okay, yes.
They do that at Sierra Medical and at the UMC. And I think there is someone who does that at Las Palmas, but I don't know his name since I'm new in the community.
Okay, so again, that's where the beautiful thing about calling 911 would be. That they, whoever the driver is, and depending on insurance, etc., they can get you to the place you need to go, and that's the most important thing. I don't have any more questions from the audience. I'm at like a minute and a half out, so I'm going to start saying my thank yous. Unless there's something you want to spit out there really quick that might take you a whopping 20 seconds. No? So think about a commercial on TV. Those are 30 seconds long. And there's a lot of information that can be put out there during that time. But I want to say thank you very much to Roxanne Lerma, again, who comes quite a bit, and also to Mikey Jimena. Thank you so much for taking the questions down. And again, Dr. Eze, who is our neurologist that was here with us this evening, and Dr. Brian August, who specializes in rehabilitation, and great doctors, both of you, so we thank you so much. And we were talking earlier about what kind of a dance each show is. Sometimes it's a waltz, sometimes it's a tango, and I thought we did a beautiful foxtrot. Good job. So if you want to watch this program again, or any of the programs that you have seen on the El Paso Physician, you can go to the television's website. It's kcostv.org. Go to programs, or go to watch actually first, and then programs, and you can find this program on there. And also you can go to the El Paso County Medical Society website. That's EPCMS, just the acronym for El Paso Medical Society.com, and find this show, and you'll be able to see it there again. My name is Catherine Berg, and I appreciate you watching the El Paso Physician. Good night.